Peace. Welcome to the YouTube live book reading of Clinical Application of Respiratory Care. Peace, everyone. Peace, YouTube. Welcome to September. We made it. We made it. So, we pick up in chapter 9, page 168. Down at the bottom. Peace, YouTube. Welcome to the 1st of September edition reading of Clinical Application of Respiratory Care. All right, here we go. The bottom of page 168. Aerosols. An aerosol may be defined as a suspension of very fine particles of liquid in a gas. Of all the pharmacologically and physically active aerosols used in medical practice, water is the most important. The use of water in the treatment of bronchopulmonary disease requires an understanding of the physical principles of aerosols. The last 10 years has produced a flurry of investigative techniques attempting to discern the complexities of medical aerosol therapy. The authors recognize the problems involved and realize that differences in technique account for much of the variance found in medical literature, especially pertaining to effective particle sizes and to the degree of alveolar penetration by aerosols. We suggest that the interested reader delve further into the complexities involved in studying medical aerosol therapy. The following discussion reviews the most widely accepted behavioral characteristics of medical aerosols as they apply to clinical medicine. Peace, highest heart, love, abundance rising. Welcome, YouTube. Peace, Coco Eloshun. Divine September. We can only alert the reader to the fact that it is by no means a totally valid application of the physics of aerosols. In addition, new developments in this field may well change basic concepts. Medical aerosols must deal with particle sizes of less than 3 microns in diameter because it is at this mass that gravity begins to lose its influence on particles, and as we shall see, it is at this size that deposition of particles in the pulmonary tree becomes feasible. We're at the top of page 169, pushing towards 1,000 subs on this channel where we read books and learn from masters. Welcome, welcome, welcome. Thank you for sharing as well as inviting others to the channel. Highest heart love. Happy September 1st. Aerosol stability. The ability to remain in suspension for significant periods of time reflects the stability of an aerosol. Numerous characteristics affect this stability. Among the more important are 1. Concentration of particles. 2. Size and nature of the particulate matter. 3. Ambient humidity. Instability is the tendency for particles to be removed from suspension. The stability or instability of an aerosol will greatly affect its clinical usefulness. Medical aerosols are believed to have optimal stability when the particle diameter is from zero point 0.2 to zero point 0.7 micron and the concentrations are from 100 to 1,000 particles per cubic centimeter of gas. We must accept the generalization that water particles or saltwater particles are reasonably stable in the zero point 0.5 to 3 micron diameter range, and that these particles maintain a basically spherical state under normal conditions. Peace. A medical aerosol must traverse tubular structures in which turbulent flow is the rule. Water or salt water solutions will not change basic chemical or physical properties when inhaled, and they have the tendency to coalesce when contact is made, i.e., when two particles of water collide, they tend to form one larger particle. Water particles have the physical tendency to form spheres so that the least surface area is exposed to the gas. Since the volume of a droplet is proportional to the cube of its diameter, 1,004 micron particles must coalesce to form a single 40 micron diameter particle. Makes sense, right? Thank you so much. We can make the generalization that as droplets are traveling down the pulmonary tree, turbulence will cause the particles to collide and form larger diameter particles. How far the aerosol will penetrate and how much will be deposited in the tracheobronchial tree is a subject to which we must devote some depth of study. Penetration and deposition. Penetration refers to the maximum depth that suspended particles can be carried into the pulmonary tree by inhaled tidal air. Deposition is the result of an aerosol eventual instability, permitting the particles to fall out on a nearby surface. Clearance generally refers to the process of removal of particles once deposited in the pulmonary tree. In relation to therapeutic aerosols, there are four major factors that are known to influence penetration and deposition. 1. Gravity. 2. Kinetic activity. 3. Inertial impaction. And 4, ventilatory pattern. Thank you for all those taking notes and reading with us. Hi, it's Heart Love to the book lovers community. We are here in this peaceful place of YouTube, headed towards 1,000 subs. Woo! Yes. Moving into September. Hi, it's Heart Love. Gravity. We want to connect a big dot right here. Thank you so much. We're at the top of page 170. Clinical application of respiratory care. To start off September, we are in chapter 9, humidity and aerosol therapy. Thank you for being here and reading with us. Gravity. Gravity will influence a suspended particle in direct relation to the particle mass. Suspended water particles between 0.1 and 70 microns follow the prediction of Stokes' law of sedimentation. This is a complex law which deals with the rate at which small particles will fall to the earth, taking into account physical factors such as particle volume, density, acceleration of gravity, and viscous resistance of air. Since we are dealing solely with water particles at the Earth's surface, we may simplify Stokes' law into a proportionality which states that as the diameter doubles, the forces of gravity tending to make that particle rain out increase fourfold. Remember that it takes a very large number of small water particles to coalesce and form a particle with twice the diameter. Ding! We may generalize the effect of gravity on water aerosol by stating that as the diameters of the particles become larger, the gravitation forces that tend to make the particles remove themselves from suspension become greater. Kinetic activity of gas molecules. Down here at the middle of page 170 in chapter 9. Small particles suspended in a liquid can be seen to have a erratic movement pattern seemingly independent of the direction of liquid flow. This movement is due to molecules of water moving at random as a result of kinetic energy and hitting the suspended particles. The particle movement caused by this molecular phenomenon is known as Brownian movement. The same phenomenon will occur with small water particles in gas suspension. Peace, peace. Highest heart love. Thank you, Olia. Olia, highest heart love. Mia, Mia. Bonjour. Merci for being here. Thank you. This phenomenon has little application in the tracheobronchial tree, but is an essential concept in the study of the efficiency of aerosol equipment. The random lateral movement of particles may result in unwanted coalescence and deposition in the generator and tubing as aerosol generators become more efficient in producing smaller particles and denser mist. This factor becomes more important. Inertial impaction. Figure 9.2. Okay, here we go. Inertial impaction is an important theoretic concept in the penetration and deposition of medical aerosols. It is based upon the physical fact that water particles have a greater mass than gas molecules. The force moving water particles in a straight line is greater than the force on gas molecules. Thus, when an airstream containing liquid particles undergoes a sudden change in direction, the particles tend to continue on a straight course. This directional divergence of the water particles from the airstream will cause a great number of water particles to collide with the sides of the bronchi and bronchioles, either at points of branching or in areas where there is retained mucus. Whether a particle will deposit in such a manner depends in part upon its location within the airstream. Therefore, the probability of deposition caused by inertial impaction increases as the diameter of the conducting tube decreases. Ding! You see that? Makes perfect sense. The more they coalesce, the more tension is building up, right? The pressure. So powerful. Okay, here we go. This type of deposition is far more important in the bronchioles than in the bronchi. Figure 9.2, schematic representation of the principle of inertial impaction. So you see the thin bar line is the water particles. And then the translucent and dotted larger um, bar is the gas molecules. And see how the stream is a schematic representation of. This is figure 9.2 on page 171 in chapter 9 of clinical application of respiratory care by Barry A. Shapiro, Ronald A. Harrison, and Carole A. Trout. So you see that there. And the streams are going in and then vacating off. In clinical practice, the aerosolized solutions will vary, as will the method of administration. There are two additional factors that may affect particle disposition: tonicity of the liquid and temperature variation. Hypertonic fluid tends to absorb water, whereas hypotonic fluid tends to lose water. Therefore, hypertonic aerosols would theoretically gain water and increase droplet size. Hypotonic aerosols may theoretically evaporate. Although it is an interesting theory, there is a little to document its occurrence in clinical practice. A more realistic concern may be associated with injecting the aerosol into a heated and humidified gas stream that will cool on the way to the patient. The evaporated water that must rain out may well coalesce with the existing droplets and increase their size. And so we know this is what, with the CPAP now, we have that direct line, and then we have the mouth class, or we have the nose and mouth class, or just the nose clamp. And I tend to use just the nose clamp because when I do your healing sessions with breathing and stretching, just put the nose clamp on, and then they're just getting 100% of that airflow through the nose, opening up that vagal and stimulating that. Ventilatory pattern, top of page 172. The previously mentioned factors that determine the penetration and deposition of aerosols are basically dependent upon the appliance and the state of the airway. This means the therapist has little control over these factors. However, the ventilatory pattern is potentially within the control of the therapist and therefore becomes the most important clinical variable determining the penetration and deposition of medical aerosols. In general, she said, amazing. Eyes heart love. Thank you so much. Oh, peace from Russia. Oh my goodness. And friends in Ukraine, all around there. We in Eastern Europe and over in Asia. We love you so much. We love you, love you. Mm, mm. In general, deposition and retention of aerosol particles are directly related to inhaled volume and inversely related to ventilatory rate. Mhm. This generalization holds true with the water particles of at least 1 micron in airways larger than the terminal bronchioles. Distal to terminal bronchioles, it is believed that the gas stream flow stops, and mass gas movement in and out of the alveolar structures is by diffusion. Gas movement is in response to pressure gradients. Thus, depth and frequency of ventilation have little influence on the deposition of particles once they have reached the alveolar level. Deposition of water particles within the bronchial tree is very definitely related to the ventilatory pattern. Since the nose will filter particles, the patient must inhale the aerosol through the mouth. Shallow breathing carries a reduced volume of aerosol per tidal volume, and a rapid breathing rate reduces the time available for the particles to settle. If penetration and deposition are the objectives, the ideal ventilatory pattern consists of slow, deep breathing and holding the breath at the end of inspiration. At the end of the inspiration, holding the breath. Very key. Very key. Gotta put one down right there. Ding! You have to put it down right there because, especially with meditation, we know this also helps to decalcify parts of our brain, is to hold the breath after the inspiration. This pattern facilitates the introduction into the pulmonary tree of a significant volume of particles. This is a practical point that the respiratory care practitioner will have to keep in mind as or she instructs and supervises patients in the proper technique of effective aerosol therapy. Water content. Thank you so much for reading with us. Hi, it's Heart Love. Happy September. Peace to all the book lovers. We love you so much. Divine Rising. Did it. We made it to September 2025. All reading books on this channel. Providing a service for the people. Wow. It's a way to go. Water content. Bottom of page 172. Penetration and deposition of aerosol are obviously dependent on the density of the aerosol mist. The total water content of aerosol gas, water vapor, plus water particles greatly affects the potential for depositing water within the tracheobronchial tree. Gas containing 50 milligrams of water per liter of gas at room temperature will guarantee 100% humidification of inspired gas, but will not be significant in depositing water in the airways. Water contents of greater than 50 milligrams of water per liter at room temperature have the potential for depositing water in the airway. When aerosol mists contain appropriate 1 micron droplet size and water contents in excess of 100 milligrams of water per liter, they are extremely effective mists for deposition in the tracheobronchial tree when appropriately administered. And here you go. Table 9.2 is the nebulizer output versus water content. Thank you so much for the likes and subs. We're reading books, learning from masters, MCAT material. This is thousands of dollars of information, and we're bringing it to you free here on YouTube. Thank you so much for joining us. Page 173 at the top. It shows nebulizer output versus water content. The output, 6 milliliters per minute, and then 3 milliliters per minute. And then it has the gas flow in liters over minute is 5, 15, 25, 10, 20, and 30. And then the water content, milligrams over liters, is for the top and beginning 1,200 milligrams over liters, then 400 milligrams over liters, 240 milligrams over liters, 300 milligrams over liters, and 150 milligrams over liters, and then 100 milligrams over liters. 1 milliliter of H2O equals 1,000 milligrams of H2O. It is important to differentiate between water content of an aerosol and the output of an aerosol generator. The fact that an appliance has an liquid output of 6 milliliters per minute says little about the mist. Table 9.2. It is obvious that the medical efficiency of aerosols is dependent upon the water content. The appliance output is important only in relation to total gas flow. We'll pause right here, continue back this beautiful September with this great reading, chapter 9 of Clinical Application of Respiratory Care. Peace and highest heart love. Happy Labor Day. Did it. We made it here. Thank you so much. Highest heart love and honor. We're doing it. Yes. Live from the light here in LA. Shaking it up. Reading books. Reading medical material for free on YouTube. Live from the light. We'll be shake it up. Read books and learn from masters. I'm Master Fitness Trainer Uriel Riley. Thank you so much. Thank you, Coco. Highest heart love, much gratitude. I'm so glad to have caught the live reading. Yes! Oh, we made it to September! I love you guys so much. Thank you for all being here. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hey ya, hey ya, hey ya, hey ya, hey ya, hey ya, hey ya. Hi, heart love. Thank you so much for reading with us. Let's take a big breath together. Here we go. In through the nose, up the cranial, down to the diaphragm. Oh, take another breath up. Ooh, thank you. Thank you. So grateful and thankful for all I have now and all that is coming to me. So grateful, thankful, all I have now and all that is coming to me. Hands open, ready to receive. I believe I deserve it. You deserve it. Let's have a couple of love water. Drink to the love life that we share together, to all our friends and family, all those that haven't made it to this part of the year. We honor you. We love you. You're always with us. To our friends and family that are with us, we honor you. To all the light workers healing the people, we are you. We feel you. We are with you. Highest heart love. I love you. Oh, love you. I love you. I love you. We did it. And we'll reconvene more chapter 9. Thank you so much for being here. I love you. I love you. You. And me. Peace, peace. I'll see you soon. Being able to breathe through my nose. Thankful, yes. That's why we're reading this book. Clinical application of respiratory care. So we can breathe better and teach others to breathe better. Highest heart love. Peace.